Thank you very much. My name is Hendrik Huthoff. I am scientific manager and head of education at the Jena School for Microbial Communication. That is indeed a PhD program in microbiology at the Friedrich Schiller University in Jena. And I do get these notifications from the waiting room. Is somebody else taking care of?
I'm taking care of that.
And I moved to Germany from having lived in the UK for a long time. And I came to Germany in 2017. And that actually coincided with the watershed publication, I could really say, of Katja Levesque. That is probably the very reason we are all together here today. She really opened up that can of worms. And I had already in the UK been PhD well-being officer in our department and had some dealings with people with mental health problems. I incidentally, during my PhD, had a mental health issue myself. I had an anxiety disorder. And when I came to Germany, I was unpleasantly surprised by the lack of support structures at the university I work at, and I think this is generally quite true, that there is a lot of stigma still attached with it. And so I wanted to establish some sort of support structure at the Schiller University. I already was familiar with mental health first aid, but at that time there wasn't an accredited mental health first aid institute in Germany, and that took until 2020 to arrive. And I'll talk a little bit about them and their remit in this presentation. Should be about 10-15 minutes, and then Olga is going to share her experience of trying to set up mental health first aid in the absence of this accredited institute. So we approached it, the same question, quite differently. I kind of waited it out until there was an accredited institute and then establish it, and Olga tried to find a solution to deal with it in the interim. So I hope that our presentations complement each other nicely today. So one thing that I always want to say with these presentations, I am not a mental health care professional. In fact, I'm originally a virologist, but hey, who needs virologists these days, right? So I've shifted my focus towards mental health. But I do run still a program on microbiology here at the Friedrich Schiller University. So I don't give any advice on treatment. I'm trained as a mental health first aider, and we'll get to what that is. But that too does not make me a therapist or qualified to diagnose anybody. And I would also ask you in the discussions to please refrain from saying anything too personal. If you have a question about mental health or mental health first aid, I don't think that this would be the right platform for anyone in the audience to say, hey, I think I might be depressed. Can you help me with that? We can answer general questions. If you have personal questions, I get that also, to get at that also at the end of my presentation, then we can direct you to the right people to talk to. But such a public platform as this, I don't think would be appropriate for too personal questions. So what is mental health first aid anyway? Well, actually, it is the analogous thing to first aid in terms of a physical health emergency. So basically, you know how to patch somebody up or assist somebody at the moment of a crisis, like as if giving somebody a heart massage when they were passing out or having a heart attack. And you could rescue them perhaps at that moment. And that is what mental health first aid is as well. It is to give people assistance when they have a mental health crisis at that acute moment when it's a problem. And this is really done through listening for the most part, and a structured approach to asking questions, finding out what the matter is. As a first aider, perhaps trying to categorize it as thinking, I might be dealing with somebody who's depressed, I might be dealing with somebody who has psychosis, I might be dealing with somebody who is at risk of committing suicide. And all these, you are then trained to give the appropriate support at that time. And so a mental health first aid intervention typically would also be a single intervention. It's not something that people would come to you regularly, because it is exactly that. It is just first aid. It was developed, I believe, in the early 2000s or so by the Australian public health authorities, and it is entirely evidence-based. And really, its core aim is to reassure and empower anybody in a mental health crisis and assist them with finding the appropriate help for them. And why is this important? Well, the World Health Organization estimates that 1 in 4 people will suffer during their lifetime of a serious mental health condition. And not only that, why is this important specifically in academia, as I believe? Because there's also a very strong age dependency associated with serious mental health conditions. And the vast majority of emerging mental health conditions occur before 24 years of age. About 75% happen in young adults. And that's also demonstrated in the 2 graphs here, 2 very common mental health problems: anxiety on the one hand, the orange bars being females and the purple bars being males. So we can see there's also a gender distribution here, anxiety being more common among females. But you really see that at the onset of, and I hope that you can see my cursor moving here over the screen, of early adulthood between up to, say, the mid-30s, that's where we really see the incidence of mental health conditions. The same is true with schizophrenia. There, the gender balance is reversed, more common in men than in females, but again, from, say, the age of 19, 18 to the mid-20s and mid-30s is where we see the majority of onset of mental health conditions. And that's, of course, exactly the clientele that we have at universities, starting perhaps with bachelor's, master's, and PhD degrees from 18 to, say, 34, if we also include postdocs. That is the age category that we have at universities. And as, of course, the work of Katja Lebeck has shown us, that the academic working environment brings with it additional burdens on the mental health. I believe I get to that in a minute as well. So another very sad statistic is that on average, it takes individuals about 8 years to seek treatment after onset of their mental health condition. And this is classically what happened to me as well. There's a lot of different factors for this. Just trying to ignore the problem being one of them, or being in denial. And usually what happens is that you build different mechanisms over this period to cope and to try and perhaps hide from yourself and your surroundings that you have a problem in order not to have to admit it to yourself and others. And then usually what happens is that a crisis occurs where the person realizes something needs to give here. And that's precisely what happened with me as well. In the final stages of my PhD, basically I had a breakdown after I handed in my thesis, and that's when everything came crashing down. And that's another perhaps counterintuitive factor, that sometimes very positive things can lead to triggering the mental health crisis. So I had managed to pull through my PhD with a mental health condition. And then when my PhD was finished and the time actually should have come to celebrate and do all kinds of cool stuff, I realized that I wasn't up for that at all. And I had to have a good look at myself. And I sought treatment. And the good news was that after about 3-4 months of cognitive behavioral therapy, I had my anxiety problem under control. So it's a bit of a shame to let it fester for 8 years. And I suppose it's one of my greatest regrets in life, that I wasn't able to look at myself in the mirror earlier and address the problem and have a more pleasurable PhD time. So I've already mentioned the work of Katja Lebeck. Why is this important in academia? Well, her work very clearly showed that academics are at increased risk, in particular PhDs. That was the focus of her work, but I think evidence is building up gradually that it extends to postdocs and even to group leaders as well, who are continually under pressure to publish, to find new funding. So academia is an environment rife with pressures that could lead to mental health conditions. Probably not something I need to expand on a whole lot in this audience, but it's always important to remember why Katja Levesque's work was so impactful, precisely because it was such an elegantly controlled study. So she compared the risk of mental health conditions in PhD students with 3 control groups that had also a higher education degree, but did not go on to do a PhD, but in a different kind of working environment. And the important numbers in this very complicated table here are the ones that I boxed in red. And that is that number in the red boxes represents the percentage of that population who are at risk of developing a mental health condition. And we see that among the PhD students, that's about 32%. And the 3 control groups, on the other hand, are only about between 12 and 15%. So we have roughly a twice to 3-fold increased risk of developing a mental health condition associated simply because of doing a PhD. And that is why her work was so groundbreaking, because it's entirely evidence-based and elegantly controlled. How was this established? That she did that with the General Health Questionnaire. This is a standardized test to assess the mental health risk in people, or risk for mental health conditions, more accurately put. It's a set of 12 questions where you have to answer, are you more or less able to concentrate at the moment than normal? Do you feel more or less useful than normal? In that case, if you were to say, I feel less useful than normal, you would score a point. The 6 questions at the bottom work precisely the other way around. So are you feeling more constantly under strain? And you say yes, more than usual, then you get a point. Are you feeling unhappy and depressed more than you usually do? Yes, you get a point. And the cutoff that Katja Levesque used in her work, if in this questionnaire you score 4 points or more, you are categorized as being at risk for developing a mental health condition. Risk being the important thing there doesn't mean that anybody who's reading these questions now and perhaps applying them to themselves, and if you've got 5 or 6, doesn't mean that you have or will have a mental health condition, but you are in a risk category. This is always a snapshot from a certain moment. It could change by tomorrow. If perhaps you're not feeling so great because you broke up with your partner, and then next week you meet somebody else, the picture might be different. However, if you remain in that score for a long and prolonged period of time, then that is certainly cause for concern, and perhaps a good reason to look at yourself if something needs to change. So typically, what kind of support structures are actually available at universities? And Brian already mentioned it. I'm part of the UniWind work group on mental health. UniWind is the German University Association, where its member universities can join working groups on all sorts of different subjects, usually focused around the PhD and postdoc period at universities. And this is what we are also finding, that the landscape in Germany is quite diverse. It's partially to do because of the federal system. Things that work in one way in Bavaria might not at all be the same way in Thuringia, because these are often organized on a state level. So your university may have its own psychosocial counseling unit, it may not. In Thuringia, where I live, so psychosocial counseling is part of the Studierendenwerk, which is a state-run organization that also provides the Mensas, for instance. And this was a problem because there's not necessarily feedback between that state-run organization and the individual universities. So, in fact, our university leadership had no idea how many of our students and PhDs were lining up for psychosocial counseling at Studierendenwerk. There wasn't necessarily a feedback loop there. And on top of that, if, say, a certain department of the university would be overrepresented, that would not be fed back to the university because of confidentiality issues. So there's a disconnect there in some cases. Another quite common support structure that you would find almost anywhere, I think, is an ambulance psychotherapy unit at your local hospital. We have a university hospital that provides it. At our university, in fact, we have two ambulances, one at the hospital, but we also have a department where psychological therapists are being trained, and they also provide ambulance services. House doctor is always somebody you can go to. That would be probably the most common way to get a referral then to a psychologist. And in fact, that's the route I chose when I was at my wit's end during my PhD. And increasingly, counseling is available online, of course, as mandated by the pandemic. And the evidence base is excellent to show that online psychotherapy works just as well as face-to-face. So there's a lot of advantages to be gained from that, because people can stay in surroundings where they're more comfortable. They don't have to go to a therapist's office. Although it has to be said that some health insurers in Germany are unwilling to pay for online counseling as yet, but I think that they're going to have to change that. And then I've got friends and family in brackets. Friends and family are incredibly important support structures, but they cannot fix somebody with a proper mental health condition. And so if you've got a friend who is depressed, it's not your job to fix them. And if you have an issue and you can't rely on your friends and family to fix you, the best thing you can do as a friend, as a family, is to be there for somebody, to listen to them. But it needs to be the individual's choice to really seek appropriate help. And one thing that also doesn't work, and we learn that as mental health first aiders, is to say to somebody, hey, I think you're depressed. You should see a psychologist, I think. That is counteractive. The person is more likely to say, what? I'm not crazy. What do you think? You know? So you have to be very careful with this. And so in a familial or friend setting, be the best friend you can be by being supportive and listening, but be careful with advice. So from this list, I felt that there, certainly at our university, was a mismatch. There wasn't anything that our university was providing directly that was visible to the students and PhDs. So I knew about mental health first aid, and I wanted to implement that at our university, but it didn't exist at the time. As I mentioned in my introduction, the accredited institute didn't arrive in Germany until 2020. I'll talk a bit more about that in a minute. So how does mental health first aid training look? It's in total 12-hour training that is usually delivered in sessions of 6 times 2 hours, where the first hour is generally theory about a certain subject, and then the second hour is this role playing, so that you really internalize this structured approach to having these conversations based on questions and answers. And they can be delivered online or in person, and cost approximately 200 euros. I think the costs have recently gone up a bit, 200, 220 euros or so. So this is well within the budget of what most universities make available for professional trainings of their staff. And indeed, when I got trained as a mental health first aider, my employer, the university, paid for that. And so the German provider for accredited mental health first aid training is the institute in Mannheim, the Central Institute for Mental Health in Mannheim, in German, Zentralinstitut für seelische Gesundheit. And they also offer trainings for instructors. And indeed, that's something that we've also started doing at the University of Jena. We have one of our staff members is now trained as an instructor, so we are offering this training in-house as well. And what are the top subjects that are covered in mental health first aid training? First of all, it's the structured approach to delivering the mental health first aid. It's a stepwise program of approaching this conversation with the person, which goes through first assessing and then asking them where might it be, trying to categorize for yourself which might be the most helpful for that person, but always framed as a question. And then you apply this to the different kind of scenarios you might run into as a mental health first aider, being the most common mental health disorders, depression, anxieties, psychoses, addictions, eating disorders, and then finally suicide and self-harm. So you learn how to act effectively with each of these kind of crises. And I should add that because you learn a structured approach on dealing with these discussions, as a first aider, it also helps you to distance yourself. So you don't take it too hard so much. And more importantly, you don't wonder afterwards, have I done the right thing or not? Have I supported this person in a proper way? Mental health first aid is an evidence-based support intervention. And when I've had a session, I can be confident that I have done, to the best of my abilities, the best thing for that person. And I don't need to stay up at night and think, did I say something wrong? So that is a great help also to those delivering mental health first aid. And there was immediately a large team of volunteers at our, or actually I should say small team of volunteers at our university interested, and they all came from the coordination of PhD programs. And why were they interested? Well, they are the people that are the unofficial go-to persons for any sorts of problems. As a coordinator of my PhD program, people come to me with problems regarding their leave to remain, residency permit, finding a flat, issues with their supervisors and colleagues. Everything comes on my desk. And previously, I didn't know how to deal with it. And now with the mental health first aid training, I know very well how to deal with it, how to separate the different problems, and it makes my life a lot easier. So we started with a small team, and we are currently expanding this. I mentioned already we have our own in-house trainer now. Mental health first aid in Germany is slightly different than it is elsewhere in the world, where Germany is unique that if you want to be qualified as a trainer, you need to have a background in psychology or psychiatry. Everywhere else in the world, anybody can be a mental health first aid trainer. But this is an additional requirement that the German Accredited Institute has set. Be that as it may, that's the framework that we had to work with. It became a bit difficult because of that reason to find a person who is a trainer, because most people who work in psychology and psychiatry are busy enough as it is. But in fact, now we have two. One is delivering the first training in our university this month. So by the end of this month, we will have about 30 university staff trained as first aiders internally. And so we will see our pool of first aiders expand from, I think at the moment we're about 10 to about 40. And the idea is that we can rotate who is on the website with their contact details, that it doesn't always end up on the plate of the same persons. So I've been doing this for just over a year now, I think. And here are some of my observations that I have gathered in my time as a mental health first aider. And this slide is, I set it up just at the beginning of this year. The first point will be something that's very well familiar to anybody who works in the field of psychology and psychiatry. The last months of the year, the run up to Christmas, November, December, is always a peak time when there is increased demand for people wanting to see therapists or seeking help about mental health conditions. And so that meant that in November and December, I was getting requests and performing about 2 or 3 interventions per week. At the moment, right now, we're more talking about 1 or 2 interventions per week. Interestingly, what we noticed, or what I noticed in November of 2021, is that 100% of those who contacted me were master's students. And the reason that is interesting is that we had actually set this up for the PhDs and postdocs, and we had not communicated it to the entire university because we started out as a small team. Despite that, the master students found our website and they contacted us anyway. And of course, we don't send anybody away. So I believe that the demand for this under the master student is still something that is vastly underestimated, certainly from my experience. I also noticed that the vast majority of people that come to us or to me, and that might be a bit biased because I'm known at my university for being an international member of staff, but a lot of those that contact me are international students and employees. It's clear that the pandemic has had a major effect on the mental health of people and also on their willingness to look at their mental health. And so I think the pandemic has had a positive impact there, where it has made the discussion about the subject a lot more open and acceptable, because I think we've all in the last couple of years have had to deal with ourselves in four walls, and it's not been easy on anybody. So that is very clear. And really what I want to highlight are the last 2 points, where I think that in academia, mental health by colleagues, by peers, can really be extremely helpful. Namely, we notice that there's a lot of things that are related specific to the academic endeavor. Things such as anxieties for exams or defending the thesis. In fact, I had one young lady come to me, and she was a very talented PhD student, was about to defend her thesis and was incredibly anxious about that. And that was a successful intervention in the way, because having had an anxiety disorder myself and having been successfully treated about that, I could give her tips on how to manage your anxieties in such an important moment when you're defending your thesis. And indeed, afterwards, she emailed me and said that she had really enjoyed her defense. But more generally, because we are staff members who work at the university, anybody who comes to us with a problem, we find that quite often this is tied, mental health is a component of the problem. And often it might be to do with things like residency permits or conflict. Conflict is a really, really big topic, supervisory conflict. And so we can then not only assist people with their acute mental health problem, but say, it sounds to me as if there's a conflict at the root here. And are you aware that we also have a conflict intervention team, or people who can mediate in conflicts? And these are the contacts that you could approach for that. So a lot of the problems that we get aren't problems that necessarily require mental health treatment. But because we know the university and its administration, we can refer to the right address to get at the root of the problem, where the mental health is really just a symptom of. So I think that can really provide added value, and why it's good to have people within your organization that know your organization be trained as mental health first aiders. Because often the mental health, as I said, is just the symptom, and the root problem might be another one. So I'm coming to the end of my talk here, and I always like to end up with, to end with this three-point message here, that it's absolutely okay to not be okay mentally. The stigma that is attached with mental illness, we don't have that with physical illness, right? And so the number that I gave you at the beginning, 8 years, is common, is average. So a lot of people take longer than 8 years to seek treatment after the onset of their condition. And that's usually because of denialism and people not wanting to accept that you're okay. Well, nobody would walk around with a broken leg for 8 years, right? So I think there's a lot of work needs to be done in stigma reduction and putting the word out there. It is absolutely okay to admit, hey, I can't handle this anymore and I need help. And the good news is that the help is out there and it's evidence-based and it works. And so those are my 3 points. You know, it's normal to not be, we can't be okay all the time. It's absolutely impossible. We're all going to lose family members or break up in relationships or not get that job that we really wanted, or not have that paper published or have that grant rejected. These are all things that are going to happen to us and are going to affect our mental health. And it's ridiculous to expect us to always be okay. So admitting that is not a problem. The help is there and it works. And then finally, absolutely anybody can become a mental health first aider. And I have found it incredibly rewarding. I have seen people flourish after a single chat. A lot of people only need somebody to listen to them for once. And I've seen it make an incredible change in some people's lives. Also, just somebody to reassure them. It's okay. It's normal. It happens to a lot of people. It happens to 1 in 4 people. You're not crazy. You're not weird. And if you want to tackle this problem, we can suggest the right help for you. So that's what I would like to say on this subject. And I think now I'd be very curious to see how Olga fared with her experience.